Hi there. Thank you for taking the time to educate yourself about borderline personality disorder, also known as BPD. If you've joined us today, it's likely that you're a student in healthcare learning about BPD for the first time, or a staff member at a treatment facility or hospital looking to learn more about the signs, symptoms, risk factors, interventions, and treatment strategies involved in caring for a patient with borderline personality disorder. This video is not appropriate for those outside of the healthcare discipline, as it does assume a degree of foundational mental health care knowledge. Our goal today is to improve your recognition of BPD by showing you real-world scenarios that could lead your future patient to seeking care for BPD so that you can support them effectively. Now, where's a good place to start? How about asking, what is BPD? According to the DSM-5, BPD is a pervasive pattern of instability in interpersonal relationships, self-image, and emotions marked by impulsivity that occurs in early adulthood within many different contexts. To be diagnosed with BPD, an individual must show 5 or more of the following 9 possible symptoms. The first symptom, frantic efforts to avoid real or imagined abandonment. The second, unstable and intense interpersonal relationships. The third, identity disturbance. This is an unstable self-image or sense of self. The fourth, impulsivity in at least 2 areas. This can be spending, sex, substance use, reckless driving, binge eating, or any other category of impulsivity. 5, recurrent suicidal behavior, gestures, threats, or self-mutilation. 6, affective instability due to marked mood reactivity. 7, chronic feelings of emptiness. 8, inappropriate, intense anger or difficulty controlling anger. And 9, transient, stress-related, paranoid ideation or severe disassociation. With so many possible symptoms and many different configurations of how those 5 symptoms can coalesce to form a BPD diagnosis, providers have found it helpful to group possible symptoms into 4 dominant subtypes. Let's take a look at one patient from each of these subtypes. The first subtype of BPD we're going to discuss today is impulsive BPD. The hallmark of impulsive BPD is impulsivity, reckless behaviors, self-harm, substance abuse, risky sexual behaviors, and intense, short-lived relations. Now let's meet Julia. This is Julia, and she struggles with impulsive BPD. Julia's boyfriend is currently breaking up with her, so she is threatening to kill herself. This is a behavior associated with self-harm. After getting off the phone, Julia goes to the bar and drinks a whole 12-pack of beer. This behavior is associated with impulsivity and substance abuse. She then drives to her boyfriend's house with a stranger she picked up at the bar. Julia is now engaging in risky sexual behaviors. The second subtype of BPD we're going to discuss today is discouraged BPD. This type of BPD is known as quiet BPD and is characterized by feelings of inadequacy, dependence, and withdrawal. Individuals may avoid social interactions and have difficulty expressing their emotions. This is inward-directed with self-hatred. Let's meet Ayana. This is Ayana. She struggles with discouraged BPD. While quiet, Ayana is feeling very intense inner emotions. Ayana usually gets lunch with her friend every weekday, but today her friend texted to say they can't come to lunch because they have a migraine, which has left Ayana spiraling. She feels intense abandonment, berating herself for all of her perceived faults, feeling like she is unlovable and wanting to hurt herself. That self-loathing gives way to anger as Ayana begins to text a stream of consciousness rant to her friend, accusing them of not caring about her anymore and leaving her to find better friends. After sending 50 texts, Ayana calls off of work for the week and doesn't leave her apartment again until Monday. The third subtype of BPD we're going to discuss is petulant BPD. Petulant BPD is marked by persistent anger, irritability, and a sense of entitlement. Individuals may manipulate or blame others and may have difficulty maintaining relationships. This is a heavily codependent form of BPD. Let's meet Erin. This is Erin. She struggles with petulant type BPD. When she doesn't receive a response from her brother, she feels ignored and abandoned. Her anger and sarcasm mask a deep fear and insecurity. Moments later, her mood shifts from rage to deep despair. She repeatedly calls her brother in an attempt to gain his attention and further leaves messages threatening him that she will kill herself if she does not hear back from him immediately. He calls her back and her demeanor shifts to happy and excited, telling him how he is the best brother and she is so happy he called. These intense emotional reactions and lability, unstable relationships, and manipulative behaviors are hallmarks of petulant BPD. The fourth type of BPD we're going to discuss today is self-destructive BPD. This type of BPD is characterized by intense self-loathing and a tendency to engage in self-harm, such as cutting or suicidal ideation. Individuals may have difficulty seeing their own worth and may feel hopeless. Let's meet Allison. This is Allison. She struggles with self-destructive BPD. Allison is currently fighting with her mother due to her overspending and gambling away her tuition money. Allison's mother wants to cut her off and limit communication with Allison entirely. Allison has a handful of pain pills and is threatening her mother with suicide. Later in the day, Allison begins to have intense feelings of hopelessness and is having trouble recognizing her own self-worth. I hope these scenarios have given you a clearer picture of how the 9 diagnostic traits of BPD can be expressed in groups of 5 or more traits in a multitude of ways. Now, let's hear about the risk factors that can lead to BPD and what treatments are the most effective to get your patient feeling well again.
For borderline personality disorder, early support is key, helping at-risk youth build emotional regulation and coping skills, involving family and therapy, and creating crisis plans can help reduce long-term risks. For the main treatment is psychotherapy, especially dialectical behavior therapy, which teaches mindfulness, distress tolerance, emotional regulation, and healthier communication. CBT and schema therapy can also change unhelpful thoughts and long-standing behavior patterns. While medications aren't first line, SSRIs, antipsychotics, and mood stabilizers can be used to manage symptoms like anxiety, impulsivity, or severe emotional swings. The overall goal is safety, stability, and long-term skill building.
The BPD population is a high suicide risk, with 8 to 10% of people dying by suicide. Many engage in self-harm as well. So a key strategy to help prevent this is safety planning. We want to teach them to identify triggers, coping strategies, and emergency contacts. We also want to provide some crisis resources. The Suicide and Crisis Lifeline is a great national resource in the U.S., and all you have to do is dial 988. We also want to point you to some local mental health clinics or crisis centers and to the National Alliance on Mental Illness support groups. We also want to encourage patient and family education to help you recognize warning signs early, and there are also some local resources in Cincinnati. There's the Newport Institute by calling 855-756-1079, and the Cincinnati Center for DBT. Call 513-268-8306.